I'm Magnus Settergren from Stockholm, Sweden, and we're going to switch gears. Yeah, sure. We're going to talk about closure devices here, and specifically MANTA. Who is doing structural work here? Okay. Are you using MANTA? Yeah. One is using MANTA. Okay, so for the rest of you, this is going to be news, hopefully then. So what I'm going to present to you, I'm happy to present our actually 1,000 consecutive MANTA experience at Karolinska Hospital, and what we have learned over the course of this study. So before presenting the data, these are my disclosures. So as you know, even in the modern era of TAVR, major vascular complication is still of concern. So it happens in around 3 to 9% of all the patients undergoing TAVR. And although minor complication is not of big concern, the major vascular complication, especially those that cannot be treated percutaneously, is associated with poorer outcome. So there is clearly an unmet need for an improved vascular closure technique. And I'm then happy to be able to present to you the MANTA vascular closure device, which is actually the first commercially available device that is designed for large bore access closure. It comes in two sizes, 14 and 18 French. The 14 French then allow you to close off access sites following 10 to 14 French devices. And the larger 18 French MANTA closure device then is compatible with 15 to 20 French devices or sheets. So these are the components of the MANTA. You can see here on the top end of the picture, you see the actual closure device, and then the ancillaries to the device, the sheet together with the introducer, and then you have the depth locator, and you will soon see how this is all fixed together and used. So what's the mechanism of action for hemostasis with the MANTA device? Well, it's basically you sandwich together with the anchor and the collagen plug, you sandwich the access site in your femoral artery. And then that is the main mode of hemostasis, but also this is supplemented by the coagulation-inducing properties of this collagen. The two components are held together by this polyester suture that is then also locked together with a radiopaque lock. Okay, so let's then have a look at the 1,000 consecutive MANTA experience at the Karolinska University Hospital. So this is a single center study of all the TAVR procedure that was done between May 2017 and September 2020 at the Karolinska University Hospital. So that was then all in all 1,048 patients. 48 patients were, however, excluded from the analysis, 24 due to subclavian access, 12 subjects because we used the 14 French device, 4 due to transapical access, and then 4 unfortunately died during the procedure. And then we had some supply chain issues in 4 patients where we did not have the MANTA available, and 1 patient was converted to ECMO. However, we were able to analyze all in all 1,000 patients in this cohort, and then the primary endpoint of vascular device-related major vascular complications occurred in 42 patients, meaning 4.2%. So what is then unique about this study? I mean, MANTA has been studied previously in several studies. However, they have been highly selective studies, excluding patients with poor access, tortuous anatomy, calcification at access site, etc., etc. This is the first true all-comer study. This is 1,000 completely unselected and consecutive patients, and no other closure device was used during this study period. And also during this study period, we had 97% transfemoral access, indicating that there was quite a bit of patients with borderline access included in this analysis. So if we look at the patient characteristics, and now we have divided them up into the patients without any major vascular complication in the panel to the left, and in the column to the right, you have the patients with vascular complication. These are the typical TAVR patients, as you can see, with a mean age of 80. However, if you look at these data, we could not detect any differences with regards to age, gender, BMI, or risk factors for cardiovascular disease. However, there was a trend towards more peripheral artery disease in the group of vascular complication, but this was not statistically significant. So basically very similar baseline characteristics in the two groups. So no help here to see why we got this complication. So if we take a deeper dive into the anatomy of these patients, once again, no complication to the left, and to the right you see the patient with a complication. And these shows then the vessel size and what kind of sheets that we used in these patients. So as you can see, the target artery diameter is pretty much the same in both groups, although a tiny bit smaller in the complication group, however, not significant. The sheet that we used, however, was a little bit larger in the complication group compared to the non-complication group. And if you combine these two, in the ratio, the sheet outer diameter to femoral artery inner diameter ratio, actually this number is higher and significantly so in the group with vascular complication compared to the group without vascular complication. Again, a little bit more about the vessel anatomy and the calcification. You remember from the baseline characteristics, we had no differences in BMI. So it is in line with that data. We can also see no differences in skin to artery depth between the two groups. Also, high femoral bifurcation that extends above the inferior part of your joint did not differ between the two groups. There was a tendency to be more anterior femoral calcification in the complication group, however, not significant. And even if we combined and looked at the patients that both had anterior and posterior femoral artery calcification, these numbers were a little bit higher in the major vascular complication group, but did not reach statistical significance. Preoperative antithrombotic treatment did not differ between the two groups. And you can see there is a substantial amount of patients that were on NOAC and warfarin. NOAC was typically discontinued 2 days before the procedure, and warfarin dosing was halved 2 days before the procedure. But even if we look at the patients with an INR above 1.5, there is actually no difference in between the two groups. So nothing in preoperative antithrombotic treatments that gives a signal why we have those complications. So what kind of type of complications did we have, and what did we do to overcome these complications? So the majority of the patient had a complication that was treated with a covered stent. And the reason for receiving a covered stent was in the vast majority because of bleeding. So this is more than 40% of the patients. Major bleeding that was treated just by prolonged manual compression or by femstop was done in about 7% of the patients. Around 40% of the patients also was treated with vascular surgery. Again, the vast majority of these patients were treated with surgery because of bleeding. I have to say that the majority of the surgical intervention that was done in this study was actually early during the study. The later phase of the study was almost exclusively complications treated by a percutaneous approach with a covered stent. So if we look at the outcomes following a major vascular complication, not surprisingly, you can see a significant drop in hemoglobin. We can also see an increase in the need for blood transfusion. However, we didn't see any increase in postoperative stroke or frequency of renal failure. The hospital stay increased by 1 day, and this was significant. But I think more importantly, we did not see an increase in 30-day mortality. So you can see here in modern day TAVR, the 30-day mortality is very low here, below 2%. And actually in the major vascular complication group, we did not have a single patient that died within 30 days. We also wanted to explore and see whether learning curve could have influenced our result in this study. And we wanted to do so both on an institutional level and also on an interventionist level. So by doing so, we investigated the center's first 100 device procedure to see whether we had a higher frequency of complication during this period. And as you can see, that was not true. It was actually lower, only 2%. Only 2 out of 100 had a complication. And then we wanted to check whether the first 20 MANTA procedures for the individual interventionists, and there were 5 of us, if we had more complication during these first 20 procedures. And as you can see, that was not true. Actually, again, lower than the overall result. Only 1 out of 100 had a complication. And also, if you look at the individual interventionalists, there was actually no difference in how we performed. So we performed equally. So if we compare this result with other published data on the MANTA device, I just like to highlight this study because it was just recently published in Circulation a couple of months ago. It's the choice closure study where the MANTA device was actually studied against the ProGlide device. And in this publication, they had major vascular complication of 7.8%, which is strikingly higher than what we could see in the 1000 MANTA study from Karolinska. And if you look at the baseline characteristics of this study, actually they are pretty similar. And also when you go into more depth and look at vessel size, degree of calcification, there is nothing telling us that there were different patients that were treated. There is, however, a quite large striking difference in how the actual procedure was done. So in the choice closure study, only a fifth of the patient actually had ultrasound-guided puncture versus 100% in the 1000 MANTA Karolinska study. And I believe this could at least account for some of the differences that we see between these two studies. So what are the lessons learned then during this 1,000 patient period? So I think the best way to handle a complication is not to have a complication. And to not have a complication, that requires meticulous pre-procedural planning. That, of course, includes today CT to assess the vessel size, to assess whether this vessel size is compatible with the TAVR device that you are planning. Do we need to switch TAVR device? Can we use SAPIEN in this patient? We also assess the location of anterior wall calcification. Where is the femoral artery bifurcation? Is there severe tortuosity? Do we need to have an extra stiff wire, etc., etc.? Even more importantly, we have mentioned this earlier, ultrasound-guided micropuncture technique should be the standard of care in 2022. The poke and hope technique is gone, okay? It's better to see what you're doing and not see what you're doing. Trust me. So not only we can avoid calcified areas of the artery and navigate away from that, but also we can ensure to have anterior puncture of the artery. And also you can use your ultrasound to actually deploy your local anesthesia on top of the artery, exactly where you would like to access the artery. By that, you can now use local anesthesia for all your patients. We haven't used general anesthesia at Karolinska in more than 12 years, actually. So, and then also, like being displayed here at the bottom of the page, you can also check your MANTA device after you have deployed it with ultrasound. The second best way of handling a complication is to be prepared. So no device is perfect, not even the MANTA device. As you can see, in 4% of the cases, we have a complication. And so that will happen when you use the device as well. But that is not a problem if you're prepared. Make sure that you have the right balloons on your shelf. It should be right sizes. You should have a covered stent. You should have uncovered vascular stents on the shelf to help you treat this complication. And I must say, the vast majority of all the complications that you have with the MANTA device can be treated percutaneously. And before we conclude, I just also like to point out, don't forget your 6 French site, okay? We also see quite severe complications, not only from the large bore access site, we see it from the 6 French site. No one is doing PCI from the femoral arteries today, okay? Everything is done by the radial artery. So, also for TAVR, you should not use the femoral artery if you don't have to. The second arterial access should be radial, okay? Then you will reduce your complication rate even further. So to conclude the Karolinska 1,000 consecutive MANTA experience, we can conclude that the MANTA device in this unselected consecutive cohort of patients is effective and safe to close 18 French access, large bore access in the femoral artery. The majority of the complications were bleedings and occlusions, and that could be treated percutaneously in the cath lab. The only independent predictor for vascular complications were actually sheet outer diameter to femoral inner diameter ratio. And more importantly, the increased 30-day no increase, in 30-day mortality in patients with vascular complication. Thank you. I believe we have a Q&A session now, or yeah?
Absolutely can.
Yeah?
Yeah, absolutely we can have a Q&A. We are a little tight for time, but we have time for 3 questions or a closing comment or 2. If there are any. I'll just
Sorry, if the access femur side has posterior calcification, can you still access at that side, or you have to avoid it?
No. Yeah, so actually in this study, posterior calcification were completely equal in the two groups. Actually, there was a tendency to be more anterior wall calcification in the complication group. However, it was actually not significant, but posterior calcification did not give any signal at all, actually. Yeah. Yeah. You need, though, to take that into account when you do this. That is important. So it's not that you can just, but you should not exclude those patients for the MANTA procedure. That is important.
Tyler?
Yeah?
My question was going to be kind of similar in that, so posterior wall calcium not being as much of an indicator for complications, do you attribute that to more accurate placement of deployment of the anchor, and that's why you avoided complications there? And why do you feel like interior wall plaques led to more complications?
I do think that, it is important. If you have posterior wall calcification, one complication that can happen is that the anchor catches the posterior wall calcification, and the anchor is then not fully opposed to the arterial wall. So this is still important. So we try to avoid that area with, again, ultrasound-guided puncture try to go below or above that area. However, sometimes with anterior wall calcification, it's why I think there is a signal that you have a little bit more complication in those patients, is that it's harder for the anchor to get completely opposed to the artery. And these are situations where we are even more meticulous in our also post-procedural evaluation of the patients. Always check with both angiography, but also with ultrasound to make sure that the anchor is really fully opposed on the arterial wall. And we have very low threshold. Even from the radial artery, we just bring down a balloon just to make that anchor really snugged onto the artery, okay? So if in doubt, just pass down with the wire, go down with the balloon from the radial artery, and then inflate the balloon to make sure that that doesn't cause problems in the future.
Terrific. I think in the interest of time, we're going to need to wrap things up. Maybe you can.
No?
Which cover stent did you use? Self-expanding or balloon expanding?
These are, the majority are self-expanding stents, yeah. And the majority are covered stents, yeah. Because the majority of the complications were bleeding, where we need to do, obviously if you have a dissection and a stenosis and no bleeding, you can use an uncovered stent. But the vast majority was self-expanding covered stents.
Great. Just before we wrap it up, I mean, what's really remarkable in my eye is that we started with 4.1% complications in safe MANTA, a highly selected group. We saw, I think by memory, 4.2 or 4.3 in MARVEL, which is a relatively unselected population. And then you go to a consecutive series like yours, which is entirely unselected, and consecutive patients with all kinds of anatomy, and we see 4.1% again.
And
so
also,
it's very consistent. The flipping that around, that's 96% success in large bore closure, which is a pretty spectacular number compared to a decade ago.
Yeah. And I have to say also, this study was actually, our results were actually evaluated not by us as interventionists. So we had another colleague that actually accumulated all these data. Yeah. So I think that's also good.
No rose-colored glasses.
No, exactly.
Yeah,
exactly.
Great.